To you there,
Okay.
Jennifer.
Okay, great. All right, good morning, everyone. My name is Jennifer Lawson, and I will be presenting our research that explored a frailty cohort of patients residing in Hamilton and associated with our music practice-based research network. Frailty is considered a multidimensional syndrome of loss of reserves in energy, physical ability, cognition, and general health that gives rise to vulnerability. Frail patients are complex and more susceptible to adverse health outcomes compared to people in their same chronological age. This research was conducted within the Hamilton dwelling patients of the Music Practice-Based Research Network. We are one of the more recently established PBRNs in Canada, which you can see described here. The first aim of our study was to create a frailty cohort of older adults among Hamilton dwelling patients of the Music Practice-Based Research Network, and next to determine their frailty, disease, and income distribution. Another objective was to study patterns of chronic disease and risk factors in the frail population using the music research database and socioeconomic patterns of derived from income and marginalization data. A final goal was to share our findings with the Hamilton Health team to provide insight into the development of targeted interventions for care and integration of health services for frail patients in Hamilton. The clinical frailty scale was used as a reference guide for physicians in the collection of frailty scores of their rostered patients. The scale ranges from 1 to 9, where 1 denotes low frailty and 9 denotes high frailty. Physicians were provided with either paper or electronic lists. And quick scoring was encouraged, where they were reasonably confident in their ability to accurately score a given patient. The scored lists were then collected, de-identified, and securely entered into a research database. In terms of income data collection, the economic family after-tax income decile group data was collected from Statistics Canada. This income metric provides a rough ranking of the economic situation of persons using after-tax income. We collected this data by dissemination area unit, and then we calculated the median decile for each DA in our cohort. We also collected material deprivation data from the Ontario Marginalization Index. This metric speaks to the inability for individuals and communities to access and attain basic material needs. Its indicators include income, quality of housing, education attainment, and family structure characteristics. We used the postal code conversion file to translate postal codes to dissemination area units. An analysis of the ratio between the postal code and dissemination area matched to each determined that a 1-to-1 ratio would be the most straightforward approach, linking each patient to socioeconomic data without significant data loss. So our final assembled cohort included patients who had a frailty score, a Hamilton region postal code, a 1-to-1 ratio in their postal code to dissemination area. They had availability of disease diagnosis through the Music PBRN research database, and as well availability of 2016 census total economic family income decile data, and as well as material deprivation quintile data. Okay, so on to our study outcome. Over 2,000 frailty scored patients were assigned to groupings of, over the 2,000 frailty scored patients assigned to groupings of low frailty, medium, and high frailty levels. We see the largest proportions of patients falling into low and medium groups. The frailty distribution of this study population was fairly normal, with a slightly skewed distribution as you would expect for community dwelling patients attending primary care. 3, which represents and translates to managing their medical conditions but not very active, was the most frequently scored item in the scale. Medium income deciles were further grouped into quintiles, with 1 designated as lower income and 5 designated as higher income. Most patients in our cohort fell to the middle quintile, and small groupings were assigned to either low income or high income. The resulting median income distribution of our cohort shows another near normal distribution, with the highest proportion of patients falling into decile 6. And here are findings of our disease and risk factor linkage analysis. We had 85 patients showing evidence of some chronic disease or risk factor, with higher frailty patients more likely to have 1 or more of these diagnoses. Also, when considering those patients that had 5 or more diagnoses, including chronic conditions and risk factors, increasing proportions of low, medium, and high frailty scored patients were identified as being in this heightened comorbid state. We then took a look at the types of chronic conditions and risk factors that were proportionally high in each frailty group. So here we see common conditions of diabetes, osteoarthritis, depression, and anxiety, and the risk factors of hypertension and hyperlipidemia, essentially appearing across the frailty groups. Then we have conditions like atrial fibrillation and COPD popping up into the median frailty group in higher proportions. And finally, in the high frailty grouping, we see conditions of dementia, congestive heart failure, and GERD appearing in high proportions in this group. Then to analyze the income data, we collapsed the median income decile data into quintiles to look at the associations between frailty groups and income status. Again, the first quintile represents low income, and the 5th higher income. The table shows significant differences among the proportions of frailty scored patients across the income groupings, but without any major patterns presenting. When we focus, though, on low frailty and high frailty groups within income categories further collapsed, we see that the low frailty group and a smaller in the low frailty group, a smaller proportion of patients fall into the lower income group, and fairly equal proportions of patients fall into either the median or higher income groupings. We see this pattern shifting in the high frailty group, where we see even proportions of patients falling into the low and median income groups, and then less falling into the higher income group. So we find that this demonstrates that patients with more frailty are associated with more socioeconomic disadvantage compared to patients with lower frailty. The material deprivation quintile data offers another socioeconomic view of our cohort. It ranges from 1 to 5, where 1 represents the least deprivation and 5 represents the most deprivation. Again, when we focus our view to comparing high and low frailty groups, we see that the high frailty patients fell, that among high frailty patients, 33% fell into the 2 largest deprivation or 2 lowest deprivation groupings, while 50% fell into the 2 highest. In contrast, we do not see the same differences in the low frailty group. So again, these data suggest that the patients with frailty may be experiencing financial stress and socioeconomic disadvantage concurrent with their frail state. So in conclusion, there were fewer patients with highest levels of frailty in our cohort, which is typical of a primary care setting. We also found increasing comorbidity in the highest frailty groups. And our data also showed that several chronic conditions and risk factors persist across as common across the increasing levels of frailty, with additive conditions appearing in each group. Frailer patients were associated with lower economic status and higher material deprivation. And to further summarize, frailest patients are vulnerable. We see disadvantage in both health and socioeconomic status. Combining these perspectives provides for targeting of those most vulnerable when planning systems of care and intervention in an equity promoting approach. And finally, these findings are contributing to the planning of systems of care and support for complex and vulnerable populations of the Hamilton Health Team. We'd like to thank both our project sponsor and funders, as well as the Music PBRN for their participation in the project. Thank you. Are there questions?
Thank you very much, Jennifer. I'm Rachelle Ashcroft. My apologies for the hiccups with starting. If anybody has a question, it would be great if you would be, if possible, share your video and feel free to just join and ask your question. We have 2 minutes for questions.
I'm surprised my dog didn't bark during my presentation.
I think we're still seeing your, it's kind of, we're still seeing your screen. If you want to stop sharing your screen, Jennifer, that'd be
okay, great.
Okay, good. Well, thank you very much, Jennifer, for kicking off this session. If there's no questions, then we'll move on to the next session. Thank you very much.
Great, thank you.
And next we have up, we have Scott Laing. So Scott, you should be.
Yeah, I will share my screen. Okay, so let me know. Can you see the presentation there?
Yes, perfect.
Okay. And hold on, I don't think I have my video going either, so you can see me. Okay, there we go. All right, so good morning, everyone. My name is Scott Laing. I work with Sharon Johnston at here in Ottawa. I'm doing my PGY3 in the Clinician Scholar Program, and today I was going to talk about COVID-19 and the impact that it's had on low-risk preventive care. So I don't have any conflicts of interest to disclose, and the funding that was used for this is provided by the PGY3 program. I have a master's grant for from CIHR, as well as some funding from the University of Ottawa Department of Family Medicine. So just a little bit of background. I won't belabor this too much because it's been in the news for the last 7 months, but COVID-19 has significantly impacted the delivery of healthcare services across the world, really. And in Ontario, there's been some work that's been done to quantify the backlog, particularly for surgical procedures. But as far as I'm aware, there hasn't been any quantification of backlogs in primary care. So the objective of this study was to quantify the impact that COVID-19 has had on preventive care, since that's primarily done by primary care. So in order to do this study, it was a prospective observational study where we exported data on a weekly basis from all active patient records at 3 Ottawa family medicine clinics. 2 of these clinics were academic clinics and 1 was a community site. The exported data included the patient's age, their sex, their rostering physician, the past medical history list, as well as information on the date of the latest PAP test, FIT test, FOBT, colonoscopy, and then we had the date and the result for the latest hemoglobin A1C and fasting blood sugar. So those are the things that are used for for screening for cervical cancer, colon cancer, and diabetes. This exported data was then cleaned and analyzed using a Python script. And this script determines three things. So first, it looks to see, is the patient eligible for screening based on their age and sex? If they were eligible, then it looks through their history list to see, are there any high risks or exclusion criteria that are documented in the patient's medical history? And then for diabetes, we had the added benefit of having the actual lab values. So it went one step further to say, if there were no exclusion criteria found, mainly being the patient being diabetic, did they have lab values that indicated from the A1C or the fasting blood sugar that they actually were diabetic? So the outputs from this script were the percentage of patients that had been appropriately screened according to the low risk guidelines for cervical cancer, colon cancer, and diabetes across all providers. It also outputted the change in screening rates from when COVID restrictions started until now. And then we estimated the number of patients that may be due for screening to restore pre-COVID screening rates. So first look at the demographics of the practice. So in total, we had just over 22,000 patients that were included. The number of providers across the 3 sites was 29. And looking at the number of patients that were eligible for cervical cancer screening, we had 7,149. 479 patients were excluded due to diagnoses like cervical cancer, or they had a hysterectomy. For colon cancer screening, we saw 7,344 were eligible for screening, and 195 were excluded because they had a diagnosis of cervical or colon cancer, or had inflammatory bowel disease, or had a colectomy. For diabetes screening, 10,992 were eligible for low-risk screening, and 1,460 were excluded because they had diabetes. So first, looking at the cervical cancer output here. So we have on the y-axis the percentage of patients that were appropriately screened, and on the x-axis we have the date. So you can see this is April, May, June, July, August, September, October, up until last Sunday. And then we've also marked on here when lockdown started, when stage 2 of reopening started, stage 3 of reopening, and then Ottawa has gone back to a modified stage 2. So those are to show you where kind of society is at. So for cervical cancer screening, we saw that during this time frame, we saw a 7.1% decrease in appropriate screening being completed. And we estimated the deficit based on the number of patients that were eligible for screening and multiplied that by the change and divided by the 29 providers, giving for our practice 17.6 patients due for screening per provider on average. We then normalized this because our average patient panel was 775 patients, so we thought it'd be more valuable to convert it to a 1,000 patient panel. So if you had 1,000 patients in your panel, it would be 22, almost 23 patients that are due for cervical cancer screening. Next, looking at colon cancer screening, we got the same setup here. So percentage that were appropriately screened and the time frame at the bottom. Here you can see that the overall change was 7.3% decrease during this the last 7 months. And the deficit for the number of patients that are needing to be screened was calculated in the same way. So 18 patients were due for colon cancer screening, and normalized to a 1,000 patient panel, that would be 23.3 patients. For diabetes screening, same setup here with the number of patients or the percentage of patients who are appropriately screened and the timeline along the bottom. And we saw that the change was less, 4.2% decrease than compared to cervical and colon cancer screening, which we think this may have an impact because of the setup. So cervical cancer and colon cancer screening have more systemic restrictions on it, where you can't really provide those by virtual care. Diabetes screening, on the other hand, you could provide by by virtual care, patients could still go and get their A1C done or their fasting blood sugar. So looking at the deficit for diabetes screening, we saw same thing, calculated the same way, 5.9 patients due per provider. And then we normalize this to a 1,000 patient panel, which would be approximately 20 patients per 1,000 patient panel. So a couple things that we found here were that COVID-19 has reduced screening rates across all three of these preventive care measures. And virtual care and reopening efforts have failed to restore screening rates. And the system-wide restrictions are more strongly impacting tests that require in-person or full lab functionality. So again, those are the cervical cancer screening and the colon cancer screening. And then from a patient perspective, we anticipate that this means patients are going to present with higher stage disease since screening had not been done. And from the primary care provider perspective, physicians or providers would be at risk for financial loss as the preventive care bonus thresholds have become more difficult to attain. So we think that there should, or there could potentially be, this is an opportunity to do more deliberate and targeted preventive care to address the increasing deficit, but also noting that systemic testing capacity would need to be increased in order to support this change or this initiative. So I'd like to thank my supervisor, Dr. Sharon Johnston, as well as the University of Ottawa Department of Family Medicine, the Ottawa Hospital Research Institute, and the CHIO Clinical Research Institute for some guidance during this study. And if anyone has any questions, I can take them now. I'll stop sharing my screen as well.
And do we have any questions for Scott in the audience? I'm very curious, Scott, maybe just to start, I'm very curious of your conclusion. Do you have any further, like a bit of an elaboration on what you would recommend for targeted preventative measures through the course of the next wave of COVID-19?
So part of like this study was actually a secondary use of data. So the initial purpose of this is that I've developed some tools for our EMR that make it easier for providers to get like a quick summary of who is eligible for screening and seeing like which patients are due. So developing tools like that or integrating tools like that into our EMRs so that providers can see very quickly and easily who is due for screening and what they're due for would be, that was the original purpose. And then it kind of got shifted to, let's see what COVID does, because we haven't done any or much prevention over the last 7 months.
Great, thank you. And did I see that there was a question? Was it any other questions for Scott? Jennifer?
Yeah, I had the really similar question actually, so it got scooped.
Okay, well, thank you very much, Scott.
Thank you.
Excellent presentation.
Thank you.
And then next we have up is Conrad Pow. And we'll turn over to you, Conrad. You are muted. And you're still muted, Conrad. Yep,
yep, perfect. Just making sure that the slides are up. Can you see the slides?
Yes, it looks good.
Perfect. So thank you very much for coming to this session. My name is Conrad Pow, and I'm a Senior Project Manager at Diabetes Action Canada. And I'm presenting the work today on behalf of Dr. Michelle Griever. And the work is using machine learning to predict patients with type 2 diabetes that are not receiving regular diabetes care. So why are we doing this exactly? Well, the chronic care model really does talk about looking after patients, whether they are in the office or not. So the care should be panel-based and proactive. And so what does this mean? It means that patients who don't show up to the office should still be followed up. So how do we do that, and how do we know who they are? Well, perhaps we can start looking at machine learning methods to see if we can predict with patients with type 2 diabetes under normal circumstances, because we know COVID just changed all that, are less likely to receive diabetes-related services. So there's our research question right there at the bottom. Using readily available EMR data, can we predict which patients with type 2 diabetes will be more likely to lack diabetes-related care under these normal circumstances? So here are our methods. We're using de-identified EMR data from the National Diabetes Repository. This is using data from 2 practice-based research networks, Utopian in Toronto and EON in Kingston and surrounding areas. We're using data from January 2015 to December 2019, and we're going to be using machine learning methods to explore the data. We have approval from North York General Hospital, REB, and also review by the Diabetes Action Canada Research Governing Committee, which actually puts a patient spin on it, as 50% of the committee is made up of patients living with diabetes. So this is how we generated the cohort. We used data from physicians who were using an EMR prior to January 2015, and at least a year prior to ensure that they were actually using the EMR properly. We used patients aged 40 years or older as of January 1st, 2015, and this is mainly to ensure that we're more likely to capture those with type 2 diabetes. They had to have been active in the EMR and have been diagnosed with type 2 diabetes as of January 1st, 2015. But not only active, they had to at least have had one office-based visit, so we know that they have actually been seen. Now, we thought about what are the expected services and visits for these patients. And to be honest, it really wasn't absolutely clear in the guidelines, so we asked a group of experts. And this was done through a survey. And we basically asked, in your opinion, for every year that a patient is active, what is the minimum number of services per year? And as you can see here, most people would agree having a minimum of 2 blood pressure visits, 2 or more A1Cs done in a year, urine microalbumin-creatine was reasonable. And you can see all the 8 here. If the level of service was provided or greater, we would assign a score of 1. And if it was less than the level, it was a 0. So the minimum score patient could receive was 0, and the maximum would be 8. And here's a distribution of scores. So you can see that it is skewed to the right, which is a good thing, meaning that most of the patients are receiving 4, 5 or more services. And you can see it's fairly stable through the years. But you can also see that there's a group of patients that are not receiving the recommended services. About 3% are not having any services despite having a visit, and 6% only had 1 service. So that's what you can see here, that's just highlighted. And in this graph here, we're looking at the preliminary analysis, and you can see the mean service level by sex and by age. By average, males and females are quite similar. There is a slight increase in the provision of services as a patient reaches age 7, which was expected. But you can see the mean score for males is 5.3 and females is 5.1. So not all that different, and therefore we remove sex from the machine learning algorithm. We train the algorithm on 2018 data, and we use that to predict the 2019. And you can see right at the top, HbA1c was a strong predictor, and this is what the regression tree produced for us. The terminal nodes, which you can see at the bottom, show the mean score of diabetes care and the percentage of patients within each node. You can see here that if a patient's score group was 0 in 2019, the mean predicted was 1. So it really didn't predict very well for a low score. However, as scores increased, the prediction did as well. So for a score of 1, the mean was 1.3. For 2, it was 2.6, so on and so forth. This is another algorithm that we did. It's called the classification tree using machine learning. And we classified groups into low, medium, and high scores. Low was a score of 0, 1, or 2 services provided. Medium was 3, 4, or 5, and high was 6, 7, or 8. And you can see here is what was predicted and observed. What is highlighted in yellow, you can see diagonal across, where the predictive and the observed were in concordance. So predicted low scores observed was 6,716 patients. And from this, the accuracy was quite good. It was 91% using the 2018 training data to predict the classification for 2019. So pretty accurate. Now, we did have limitations. We caution that these are very preliminary results. We have not looked at all the data or all the possible algorithms. The samples were not independent, meaning that patients that were seen in 2018 could have been seen in 2019 as well. We will repeat the analysis and replicate and cross-validate using independent samples. And what this means is, for example, training may be done in one of the networks, and we can do testing in another network. And we will also add variables that we think may be correlated with less or more provision of services, such as socioeconomic status, which is available for our patients using geographic information systems. And we'll also be testing additional models, either regression-based or other. So just acknowledgements. Grateful to Inspire PHC for the funding for this project, to family physicians for donating their data for public good and public benefit, Diabetes Action Canada for the development of the National Diabetes Repository, North York General Hospital, which is our administrative hub for the repository, Department of Family and Community Medicine at the University of Toronto, and actually North York General Hospital as well. And in that, I will open it up to questions. I will say that I am more of in the governance and making sure everything works, but we also do have our senior author who is our analyst on the call to answer questions as well.
Great, thanks very much, Conrad. So opening up for questions, Eric, do you have a question? I saw that you oh, okay, well, if so, Tao, do you have a question?
Oh, Tao is our analyst who will help answer.
Jackie, please go ahead. Jackie.
Hi, okay, can you hear me? I'm not sure. I turned on my video just to say hi. Thanks, that's really cool work. I just have a question about some of the analysis decisions. And so you have 2015 to 2019 data, and I'm curious why you only use 2018 data to train the models. And then also, in addition to like sex, did you consider other socio-demographic variables as predictors? And how did you go about deciding whether to include or exclude them?
Okay, perfect. And with that, I'm going to have Tao answer that question.
One thing is like this is a preliminary study, so we just used the 2018 data to do the training, and but like in the future we'll probably take a more holistic approach to look at the data, all the data we have. And in terms of variables, like yeah, we think like also because it's a preliminary study, so we only look at available the variables that we come to our mind immediately. But we think like a social income, status would be probably will be a strong indicators. And actually, if you look at the model we have produced, HbA1c is the one strong predictor for the patient who were likely to miss the diabetic care. So basically what it means, like if the providers notice a patient haven't done their HbA1c like a scheduling, they probably should be follow up with the patient and see what happens.
Cool, thanks. I'll watch out for the future work too. Thanks.
Thank you.
And any other questions? If not, thank you very much, Conrad and Tao, for your presentation. Excellent presentation. And our next presenter we have up is Soha. I'm not seeing if our next presenter is Soha.
Yes, I'm just going to share the screen now. Sorry about that.
Okay, perfect.
I apologize for the sound of construction in the background.
We understand.
Can you see the presentation?
No, we don't have your screen shared at the current moment.
Yeah. Okay, let's try this.
Yeah, we do see it.
Okay. And I will just open my camera as well. And everyone can still see my slides?
Yeah, we can see your slide.
Okay. So I'll begin then. First of all, thank you for the opportunity to present today. And just to introduce myself, my name is Soha Shah. I'm a Care of the Elderly PGY3 resident training here in Ottawa. So I'll be presenting a research project that I, along with my team, have been involved with for the past several months. The project title is the evaluation of the clinical questions asked by primary care providers in long-term care through eConsult, which I feel is a particularly relevant topic given our current healthcare landscape. So just before we begin, I have no disclosures. And I'd also like to acknowledge all of our eConsult partners listed here. I will provide a brief overview of eConsults, but the goal for our purposes is to improve specialist access for all long-term care residents across Ontario through the use of eConsult.
So sorry for interrupting. Can you put your slides in presentation mode so that they're bigger, because they're not advancing currently?
Oh, okay. Let me try. Sorry about that. Let me try that again.
Yeah.
I have them here. Is that working?
Yeah, that's great.
Okay, and so I'll just advance the slide, and these slides are advancing well?
Yeah, it looks great. They're advancing fine.
Okay, perfect. Sorry about that there. This is virtual care life. So as I mentioned, I'd just like to acknowledge our eConsult partners listed here. And as I said before, I will provide a brief overview of the eConsult service, but the goal for our purposes is to improve specialist access for all long-term care residents across Ontario through the use of eConsults. So what is eConsult, and why is it especially important in long-term care? So for those of you who work in long-term care, you are well versed with the unique challenges of patient care in that environment. The elderly and other medically frail patients often require extensive collaboration with specialists to manage multimorbidity. According to the Ontario Long-Term Care Association annual report from the last 2 years, there are over 100,000 residents cared for in long-term care homes each year. 97% of residents in long-term care homes have 2 or more chronic conditions, and 90% of these residents also have some form of cognitive impairment. However, accessing these specialists is often quite challenging and sometimes nearly impossible by conventional means. There are several barriers that exist with our patients being able to seek specialist care that are listed here. And these include challenges with accessing the appointment, the need for support, and limited diagnostic tools on an outpatient basis. And so as a result, many residents are often not able to attend these appointments or are just not referred altogether. So a solution to this is the eConsult service. In brief, this is a secure web-based tool that allows doctors and nurse practitioners timely access to specialist advice and that often eliminates the need for an in-person specialist visit. It can be used in all care settings, and it offers direct provider to specialist communication via the eConsult portal, which is similar to email communication. eConsult is available through the Ontario eConsult program, which is funded by the Ontario Ministry of Health. In the interest of time, I will provide some resources at the end if you are interested in learning more about the platform or if you'd like to sign up. But essentially how it works is a patient's doctor or nurse practitioner sends a question to the specialist using a secure web portal. The specialist is able to review the clinical question and any relevant attachments, such as lab work, imaging, or documents. And this is typically done within a span of a week. The response is received by the primary care provider, and that leads to one of two actions. And so either the advice can be considered in the primary care provider or PCP's care of the patient, or the PCP can refer to a specialist to continue on with the recommendations. There is a mandatory closeout survey at the end where the primary care provider can rate the quality of advice and note the actions taken. There are currently over 90 specialty groups in Ontario, including a new COVID-19 specific group. But within the geriatrics heading, there are several subspecialties, including care of the elderly, frailty management, geri-med risk, medication and polypharmacy, and then the psychiatry or geriatric psychiatry. And of note, there are over 6,000 e-consults submitted per month. Additional benefits include fast response time within a week, but often as quickly as within 2 days, compared to the long wait for in-person assessments. There's no cost to the patient or provider, and use of the service can be billed by the primary care provider as well as a specialist. It's also secure and efficient. Most importantly, it can help improve equitable access to healthcare for all patients. And also important to us lifelong learners is the capacity for knowledge sharing and teaching that can be achieved within the responses. And I personally have benefited from that. In terms of usage, between January 1st, 2017 and September 30th, 2020, there were 990 long-term care e-consults alone in Ontario. The population rate given here of 5.21 e-consults per 1,000 long-term care residents is actually a higher population rate compared to that of the general population in Ontario. So moving on to our project, the objective was to understand the clinical topics and types of questions asked by long-term care providers via e-consult. And so this was a retrospective review of all e-consult cases submitted between January 1st, 2017 and December 31st, 2018 on the Champlain base e-consult service by primary care providers in long-term care. And so this represented a total of 113 cases. Cases were classified using two validated taxonomies. So these were modified versions of the International Classification for Primary Care version 2, or the ICPC-2, and the Taxonomy of Generic Clinical Questions, so the TGCQ. The ICPC-2 classifications were used for content classification or clinical topics, and the TGCQ was used for question type classification. And then these were modified by our case reviewers to include clinical topics and question types specific to long-term care. There were 3 of us that reviewed the cases. We initially reviewed the same first 40 cases to validate the taxonomy and ensure reliable classification. We then realized that more than one question type was often asked, and as such, we modified the taxonomy to classify a second question type where appropriate. And then descriptive analyses were used to examine the content and question type classifications, service utilization data, and responses to the mandatory closeout survey. So of the 113 cases, 49% were submitted by a nurse practitioner. The median resident age was 82 years. The median response time was half a day. The fastest response time was 15 minutes, and 91% of cases received a response from a specialist within 1 week. Regarding the clinical topics, the highest proportion was skin or dermatology at 39%, followed by cardiovascular or musculoskeletal at 8% each. But as you can see here, there was a wide array of specialists that were accessed within long-term care. In 42% of cases, providers asked more than one question type. However, in 79% of cases, these were closed after a single question or response interaction. The remaining cases involved continued communication or follow-up through the portal between the primary care provider and the specialist about the case. So what types of questions are asked through eConsult? So this bar chart, I know it's a little bit busy, but it highlights the number of questions of a particular question type. The orange bars represent question 1 and purple represents question 2. Additional questions were not classified. And so the question types fall into 5 broader categories, and these are drug treatment, diagnosis, management, non-drug treatment, and epidemiology. And then these were further subdivided into more specific categories. So under drug treatment, determining the most appropriate drug to prescribe, indications or goals of treating a particular condition, how to prescribe a particular drug, and adverse effects. Under diagnosis, cause interpretation of clinical finding, determining the most appropriate test, and interpretation of test results. Under management, so other accounted for questions that didn't specify drug or non-drug type. So this could have been a combination of drug, non-drug, procedural, lifestyle management that were asked by the provider, or general what should be done statements that were, again, asked by the provider of the specialist. The most common questions pertain to drug treatment, diagnosis, and management, and these are highlighted with the larger numbers. And in looking at situations where multiple questions were asked, most commonly the first question asked about the cause or interpretation of a clinical finding. So that's the orange bar in section 2. And then the second question most commonly asked how best to manage care or determine the most appropriate drug to prescribe. And those are the larger purple bars in sections 1 and 3. So 59% of eConsults provided long-term care providers with advice for a new or additional course of action that was not otherwise considered prior to the consult. And then 33% of cases, so in green here, it confirmed a course of action that was previously considered. In 39% of cases, so here in green as well, a referral was now avoided. So providers planning to refer did not need to proceed with the referral. And in 26% of cases, a referral was still not needed. So in total, 65% of cases were resolved without the need for a face-to-face interaction. And in 25% of cases, a referral was still needed, and often this transpired as the eConsult specialist confirming the appropriateness of a referral. And in 3% of cases, a referral that was not planned was initiated following the advice from the specialist. In terms of survey outcome measures, so part of the closeout survey asks primary care providers regarding the educational value of response in guiding management, and 86% of long-term care providers rated the response as 4 or 5 out of 5. And that's comparable to the results obtained from community-based eConsults outside of long-term care. 53% of providers agree or strongly agree that the eConsult case addressed an important clinical problem that should be incorporated into future CME. And again, this is similar to the community results as a whole. So the results of this taxonomy study highlight the clinical utility of eConsults, especially in environments such as long-term care, where there are often several barriers and layers with accessing comprehensive care. And especially in our current pandemic, being able to seek this care while minimizing exposure risk with external transfers is invaluable to these vulnerable and at-risk patients. As well, access to specialists on an outpatient basis is even more limited in COVID-19. The high frequency of cases with 2 question types is reflective of the medical complexity of most long-term care residents. And from reviewing the cases on several occasions, I did notice considerable back and forth between the provider and specialist within a short timeline. However, there is a high proportion of cases that are resolved within the single interaction, which again highlights the ease of using such a simple platform in a seemingly complex environment. But again, with more complex cases, there is that ability to have follow-up discussions within the portal and still resolve the case within that interaction. And also factoring in the quick turnaround time, there's always that opportunity to re-e-consult within a short period of time. In terms of CME, the case topics, for example, the high proportion of dermatology cases can be useful in planning curricula and in targeting primary care provider training. So regarding limitations, we do recognize that the sample size is limited given the timeline and the usage of e-consults within long-term care homes at that time. And as well, depending on how the primary care provider is identified in the system as their primary organization for their e-consult account, some primary care providers who work in long-term care homes were missed, and some non-long-term care patient cases were included because if they had a primary care provider who also worked in long-term care. So to conclude, primary care providers working in long-term care use eConsult to seek diagnostic, treatment, and management advice from specialists in most clinical areas, particularly with dermatology. eConsults facilitate timely, resident-specific, and practical recommendations to support clinical decision-making. Primary care providers can obtain specialist advice without the need for external transfer or an in-person visit. And therefore, implementation of eConsult should be a priority within long-term care homes to optimize the care of complex and vulnerable residents. So there is time for some questions if anyone would like. And if anyone would like any more information, some resources are provided here. And I also just wanted to acknowledge the project leads and team members who contributed to the study, the final report, and this presentation.
Great, thanks very much, Soha. Let's open it up to questions. Any questions from the audience?
It's Jennifer. I have a question.
Yeah, go ahead, Jennifer.
Just wondering, you highlighted some quick turnaround time with respect to responses to the questions. Are there any categories that you determined through your analysis that are more, you would consider the most time sensitive and perhaps weren't meeting the mark in that regard?
So unfortunately, I don't have that data available at this time, but anecdotally, I guess, in myself reviewing the cases, it was, I'd say, probably most often drug treatment or seeking investigations where there was time sensitivity. And often, again, anecdotally was related to patients in long-term care with behavioral issues that were not able to be managed within the home. I don't have the data again, but that's just anecdotally in myself reviewing the cases, what I remember being most time sensitive.
Maybe I could jump in. It's Claire Liddy here. Great presentation, Soha. Yeah, so we do this is for non-urgent. Try to make sure that it's appropriately used. Service where you could make it time sensitive for urgent cases if you had a provider group that would be willing to, respond within a certain time. But right now, it's as soon as you get a response within 7, and if it's within 7 days, then that has met. We really try to discourage the using it for urgent. However, as I said, if you had like a group of internists or emerge docs or, a provider who would be willing to, provide an answer within a shorter time, then you could set that expectation up.
Thanks very much, Claire. So I have a question. I'm just wondering, were there any questions related to mental health or mental health care? And if so, where did those fall? Was that within like the management and other providers resources category, or where would those types of questions have fallen?
So that's a great question. There were several questions related to mental health. And I'll just pull up the chart. Often in terms of the question itself, it related to management, drug treatment. Most commonly, if I remember off the top of my head, it related to the type of management and then was classified accordingly in that way. Often as well, there were again, anecdotally, there were cases that we reviewed that related to adverse effects of psychiatric medications, and then those in terms of clinical topics were classified under the adverse effect category.
Thank you very much.
But there was a separate psychiatric category as well, but the ones that I remember most, at least that came up in the chart that I presented, were more so related to the adverse effects.
Great, thank you. Any other questions from the audience? If not, I want to say thank you to Soha for a great presentation, and also thank you to all the presenters in this session. We greatly appreciate your participation and sharing of your current work. We now have a short lunch break from now until 12:15. So please do come back at 12:15 to the next session of breakout sessions. Take a look at the poster presentations in our conference app, and hope you're having a lovely conference day. So take care, everybody.
Thank you.